Dwight Pratt, principal. Hi.
Sean Dean, speech and language pathologist.
Taylor Gregory, 5th grade teacher.
Holly Bitcon, resource specialist.
See you again, nice to meet you.
Aura Hassan, program supervisor.
Kelly Makashi, mother.
And in the Zoom call we have Dr. Beer.
Hi, I'm Melissa. I'm an audiologist.
Dr. Holly, do you want to introduce yourself?
Sure, I'm Dr. Holly. I am a special education law advocate and youth child developmental specialist.
Okay, so Melissa, do you want to briefly summarize the results, and then if mom has any specific questions?
Sure, do you want me to share my screen?
We have it printed.
Oh, okay, great. Yeah, would you guys like me to summarize, or do you want me to go through each section?
I think maybe just highlight each section high level and then get to the key points that need to be articulated.
Okay, perfect.
And maybe just direct which page you're on, since we're
Perfect. So page 1, we'll just skip that's demographics. Page 2 has some history. And then the first 2 parts of this are not tests that I did, but questionnaires I gave to mom to complete. It's just a way to capture maybe some functional listening difficulties that a parent or a provider is noticing in a student. The first one, the scale of auditory behaviors. If the patient's score is less than 30, we consider that, hey, let's investigate this further. There are enough listening concerns that we want to dig into it. And then I just list the ones that she had, I'm like pointing to my screen like you guys are watching me. I listed the ones that she had marked as noticing as happening frequently or often. And then Fisher's auditory problems checklist is another one. And it kind of elicits information about multiple areas of auditory processing, and in general, regardless of age, a score of 72% or less is an indication, just like that other one, that you want to investigate it a bit further. And mom had marked several items as an area of concern, making Amelia's score 40%, which is much lower than her age range mean, definitely lower than 72%. So I just kind of like to do those. You know, sometimes the test results might not really capture whatever it is a parent or a provider is reporting, or vice versa. Sometimes a parent or provider reports, oh, I don't see any of this, and then the test results don't match with that. But in Amelia's case, I think those kind of subjective observations match really well with what we measured. Any questions about that first part?
I don't have any questions. Do you guys have any questions?
Okay, great. So then, the purpose of me seeing Amelia was really for a central auditory processing evaluation, but I wanted to repeat her hearing test because she has a history of, some chronic middle ear issues, and unfortunately, kind of like a failed surgical attempt at patching hole in the eardrum. So right now, Amelia's kind of walking around with holes in her eardrums, and this does impact her hearing. So mom had provided some audiograms from Kaiser, and her hearing loss isn't so great that it precludes doing a central auditory processing assessment. Sometimes it does. Sometimes we can't do it because there's no way to fully separate at what point in the auditory system a disconnect is happening. I think Amelia's underlying inductive hearing loss, I'll get to that, with her eardrums, absolutely is part of some of her listening difficulties, but I think it's both. I think it's both this conductive hearing loss and central auditory processing stuff. Because it's really with a type of hearing loss she has, a conductive hearing loss, that simply means sound isn't being conducted through her eardrums like it normally would be if they didn't have these perforations in them. So anybody with a conductive hearing loss, they simply just need sound to be made louder. And so I can do that with the central auditory processing assessment. So I just want to make that clear. Her hearing loss does not preclude doing the rest of the evaluation. If it had, I wouldn't have done it. But so I repeated the hearing test, and she's got excuse me, my toddler has brought home a wonderful chest cold.
Yeah.
In both ears, she's got some conductive hearing loss. We call it minimal to mild, kind of in the moderate range in the left ear. And it's mostly in the low frequencies, but then she's also got a sprinkling of it in the higher frequencies as well.
Is that in both
So-
ears, or that's in the left or right ear?
In both ears. In both ears. Am I able to share my screen?
Go ahead.
Would that be okay?
Yeah, I
Sure.
think we
Just-
need rights.
Yeah.
Are you able to connect it there if people need to see it?
Mhm.
That fancy screen
I don't
that
know
you
if it'll
have,
take
that
away-
nice screen?
I don't know if it'll take away from her though.
Fancy.
Okay, you are
The
full,
fancy
folks.
decoration.
No, just because we were talking about it earlier.
Expensive wall art, there you go.
Just because we were talking about the screen before.
Right.
Oops. Thank
Do I
you.
have it?
I just want to keep pointing at my.
She's looking at this
Okay.
one.
Thank you.
Is it okay if I just give a brief overview of the
Yeah,
hearing test?
absolutely.
I think this just kind of helps to make sense of some things. Is that all right?
Yeah, absolutely.
Okay. So when we're testing somebody's hearing, we're seeing how loud along the y-axis we have to make each of these pitches or frequencies until they can hear them. We have this huge range for what we call normal hearing. Some audiologists say it's up to 20, some will say 25. So you look at this and you might be like, well, Amelia's mostly got normal hearing. But the thing is, I think that this is like not really fair for a student because she does have a hearing loss at some frequencies, 35, 45, 25, 20 decibels. This is a big difference between her peers that are really in this like 0 dB. 0 isn't an absence of sound, it's just where like really healthy young people can hear. So another thing we do is we measure how soft can we make sound until the patient can understand speech. And again, she's like right at this 20 to 25 value. This is what's categorized as minimal, borderline mild hearing loss. 20 to 25 decibels, you know, most kids are like in, like I said, in that 0 to 5 range. So Amelia, compared to them, it's kind of like she's walking around with earplugs in her ears. So I just brought that up because I think it would be helpful, and I know we'll get into that later, for her to be considered for DHH as well. I believe that minimal to mild hearing loss can rear its ugly head. Any questions about the hearing test?
No, it makes sense. I appreciate how you're explaining it. I get it.
Thank you.
Yeah.
Well, and all
So,
of us, just so you know, I don't know how old everybody is there, but like by the time you're in your like 30s and 40s, you're probably like right around here, really, really good. And then we start to like drop off in the high frequencies. That's why it's hard for us in like restaurants and bars.
saying
Yeah,
I'm
I don't know if y'all are like, we really have to meet up. We just go to somebody's house. And so, you know, Amelia's kind of got this reverse shape, and that's going to impact her in the classroom. So I think then when you take that into consideration within the central findings, I think she's just having to work like so much harder than her peers to not just hear, but to process what it is she's hearing. So that's just the first part. And
I just want to make one comment, just for the record, that just to highlight that the previous audiogram that she had with Kaiser was done 6 months ago, and so based upon Dr. Beer's findings, there's been a significant drop. So I was not prepared for these findings because this is a rapid loss in the last 6 months. So just for the record, I was
you summarize those results for me? Because I didn't have access to that. For 6 months ago, what was
Kaiser
showing?
audiogram.
I can send them to you.
Okay, thank you.
Yeah. So she had a botched surgery in the summer. No, when I think early in August. 'Cause she was out of school for that.
2020.
Yeah.
This yeah.
Pretty,
Um,
it was pretty surprising for the family in terms of the progression of the loss. It wasn't
2021?
expected.
No, this last August.
2022.
Yeah, 2022.
Yes.
I think that was the
She was school for it.
How long was she miss? Like a day? Or she was like a week? Or I don't remember her.
It was
being
I don't know. I'm sorry. I don't remember. I'll have to go back and look up the reports. It's all kind of blurring. But
So
but at the end of the
it's
day,
new.
she had a
Yeah.
botched surgery, and not prepared for these findings was not on my radar. And so trying to deal medically, because as Dr. Beer said, this is a conductive hearing loss. So as my mother has also attested, if we can get the eardrums patched, the conductive hearing loss could correct itself. But that's not going to be feasible for us right away due to logistics with insurance and medical changes. So, but that would be a goal. But just that this was a surprise finding for the family.
Yeah, and I'm sorry, Kelly. I certainly didn't mean to add more.
No,
to
it's
it
okay.
either.
Just
If
put it out there
anybody's
for the
there,
record.
I think it's also, I think sometimes audiologists will say, no, it's just some low frequency hearing loss, some conductive hearing loss, but it's been going on for a while. And I'm a big proponent of minimal to mild hearing loss. I'm so sorry. Contributing to listening difficulties. Not the perfect analogy, but have you ever had like some mild salsa and it's not very mild? It's like, I think mild isn't like maybe the best word
You're right.
that we can use, So so I think I just really wanted to highlight this because I think this is a part of Amelia's profile right now. And yeah, it's hard you can't just like go in and magically get it patched. They tried that, and it didn't take. So I know Kelly's trying to figure this out where if Amelia can be a candidate for the surgery again. So yeah, any other questions about the hearing test part?
Keep going. We got a lot to cover.
Okay, I'll speed it up.
No. I don't mean it. Just this. It's a lot of information. I didn't mean it like that. Just that it's a lot of information. So I want to make sure we.
There's a lot of information here. Okay. All right. So overview. What is central auditory processing? I won't read all of this. Behavioral observations. I just always like to note how a student was in the sound booth. Amelia had no difficulty maintaining attention. I didn't have to repeat instructions, and her response time was normal. So all of that just to say that I interpret these as like being a valid and reliable indicator of her central auditory processing skills. So I really like to focus on 3 domains of central auditory processing. It's not enough to just say, oh, this person has auditory processing weaknesses and this person doesn't. Everybody has a different profile. And so we kind of split it up into 3 domains. And I'll just go through each of those and talk about how Amelia did in each one. The first one is something called auditory discrimination. This is just how well we're able to kind of decipher or decode speech when it's less than ideal. We kind of stress out the auditory system during testing. We try to emulate difficult listening situations. We add background noise. We put speech through a filter to make it kind of mumbly, and we speed it up. And Amelia as a whole had an overall weakness in this domain in both ears. Now, if she had, and this is confusing, if she had a different type of hearing loss, I wouldn't be able to sort that out. Like if she had like a hearing loss that's at the level of her auditory nerve or her inner ear, I would say that could be the hearing loss, that could be central. It's really hard to parse out But with her, with the conductive hearing loss, again, I simply just had to make the test stimuli louder. So I interpret these as being, and this is in my summary, like mostly central in nature. Okay. So her scores, you know, the normative scores on all of these, like right here, if a student has a score of 72% or less, it's considered abnormal. 72 is 2 standard deviations below the mean for that age group. So it's pretty like strict criteria, right? It's not just 1 or 1.5, like it's 2. So if it's at or below that,
She's looking right here.
Weakness. Oh yeah, should I stop sharing my
No,
screen?
it's okay. I'm seeing it. I just was letting them know. Just because, yeah. Keep going.
Okay. So big picture, overall weakness, both ears. And then she had really a lot of difficulty with the next domain, which is absolutely a central auditory processing skill. This is called dichotic listening. This is just simply how we either integrate what we're hearing from one ear with the other ear, or our ability to separate it out, block out one ear and focus on the other. And this really taps into how the right hemisphere and the left hemisphere communicate with each other. This also taps into some higher like language processing skills. So Amelia had a tough time. Again, excuse me. Amelia had a tough time. She had like kind of what's considered to be a pretty typical left ear weakness on this first test. You'll see even in the normative scores, it's normal for her age to score higher in the right. People up until about their teenage years do have a right ear advantage for these tasks, particularly if they're right-handed. But then she no longer has that right ear advantage when we use a different type of test that's a lot more complex. This one, we're just having the patient repeat back numbers. This one, they're having to repeat back sentences. So again, I don't view this as being related to her hearing loss. I view this as a very central skill. The next domain, temporal processing, this is just kind of like the timing and rhythm aspects of sound, our ability to follow intonation, our ability to maybe pick up on what somebody means by what they say and how they say it. This was an area of strength for Amelia. So 2 domains out of 3. She has difficulties with, coupled with that minimal to mild conductive hearing loss. On this page, the summary, that's where I just kind of summarize what those findings can be associated with. Do you want me to kind of go through some of those, or has everybody had a chance to
I
read
would say
it?
go through the ones that pertain specifically for Amelia.
Will do.
If you can.
Okay. So, auditory discrimination, and I mean, I'm just going to read this. And I'd love to know if this, if this resonates with what you see as a mom, or with what you see as providers.
Hang on, Dr. Beer.
Oh,
We're
sure.
gonna introduce one more team member here. She's connecting to audio. Hi. Thanks for being with us. Will you introduce yourself to the team?
Yes, so I am Jaira Manchego, and I am a deaf hard of hearing specialist.
Nice to meet you.
Nice to meet you as well. Thank you so much. And just I wanted to before we start, I did want to share to the team. I'm kind of overbooked, so I do have to leave. I have another meeting at 2:00, but I will do my very best, to support in this meeting as
Thank you.
Hi, I'm Melissa. I'm the audiologist, the outside audiologist, and I already reviewed the audiogram with the team, but I'm just summarizing the central auditory processing findings.
Thank you.
Yeah, so In addition, I already kind of discussed the minimal to mild conductive hearing loss and how that might not sound like a lot, but how that really can impact a child in the classroom. And now I'm just going into, in addition to that, higher up in the auditory system, Amelia also has some central auditory processing weaknesses. And in that first domain of auditory discrimination, these weaknesses are associated with reduced sound blending, sound recognition skills, mishearing, substituting similar sounding sounds, what, asking for repetition, misunderstanding longer spoken directions, longer narratives, difficulty in noisy reverberant settings, difficulty, and some of this is also with mild conjunctive loss. Understanding speech that's really distant, faint, unclear, fast, unfamiliar accent, really being supported by visual clues and having a tough time taking in information only through the auditory channel, reduced auditory attention and processing speed, especially in background noise, and then the last one I'm sure we can all relate to, listening fatigue. Okay, that's a lot. Binaural processing or dichotic listening. These weaknesses, again, difficulty processing those longer spoken narratives or multi-step directions, needing more time to process information. I think I shared this with Mom, we lovingly call this at our clinic the deer in headlights look. Having a tough time ignoring something to one side or integrating all the information heard from both sides, multitasking, doing certain things like listening and writing at the same time. It can be associated with difficulty translating one's thoughts to what they want to say or what they want to write, being distracted by sound, or finding sound to just be overwhelming. Okay, so that's a lot. That's a lot of what they're associated with. Temporal processing, again, that was a strength for Amelia. Okay, so, I summarize here. I talked about this at the beginning. Both conductive hearing loss and weaknesses at the discrimination and integration levels can interrupt the true process of auditory processing, which is basically that entire process from when we hear something, identify it, discriminate it, process it, integrate and organize an output or a response. And then, like I said at the beginning, while that minimal to mild hearing loss can contribute to the findings, I interpret them as being mostly central in nature because it's conductive. But then I said Amelia should be assessed for DHH eligibility, and that my results, she does meet diagnostic criteria for central auditory processing disorder, which is included as OHI. Okay. Questions about the findings?
None here.
All right. Thank you for a very comprehensive overview.
Sorry if that was too much.
Dr. Holly, do you have any questions for Dr. Beer?
No, I don't. It was very, very comprehensive. I'm just really interested to hear how we can get this new data and findings on both fronts and look at current services and project to what's going to be needed currently and next year.
Okay. Is the team wanting to, what is next on the agenda? Do you want me to
Did we go through the recommendations? Did we go through Dr. Beer's recommendations?
Okay.
Yeah, let's go through your recommendations, Dr. Beer, and then from there, DHH and Sean Dean Speech and Language will kind of say next steps.
Perfect. Excuse me, everybody. I am so sorry. I tried to take a bunch of meds. It's not working. Okay. I always kind of, for school assessments, organize it in 3 areas. One is just a general recommendation. The other one is overall communication management. And then some are just like very specific to an academic environment. So the general recommendations, the one I just want to pull out here is that one of my favorite resources is something called The Relationship of Hearing Loss to Listening and Learning Needs. Did you all get those?
Yes.
Yes, the two
Yeah,
forms,
I
yes.
like those. They just kind of like will take an audiogram and translate how it might present in a student in the classroom. So I included the ones for minimal to mild hearing loss as well as a low frequency or reverse slope. So I'll just call out some of these really like important ones. And then some resources, for mom to check out. Okay, overall communication management. Mom and I didn't have a long chat about this, but if surgery isn't possible or if they recommend it for way down the road, I do recommend that she be fitted with hearing aids. I think that would really help her. And then the second recommendation is that she work with a speech language pathologist to oversee treatment strategies to strengthen those weak auditory processing skills. We follow the ASHA guidelines for how to treat central auditory processing disorder, and it's kind of a threefold approach. The first one is something called bottom-up intervention. This is also known as auditory training. This is simply doing exercises that strengthen listening skills. It's like PT or OT. It's working on the connection from the ear to the brain. And so I put down some different computer-based programs that would be appropriate for Amelia here. Computer-based programs we like in our clinic because then the family can do them at home too. Another part of that is top-down direct intervention. This is kind of working on certain skill sets. This is now not from the ear to the brain, but from the brain down, top down. How do I ask for help? How do I realize when there's a listening situation that's not working out for me? So these can also be targeted in speech language therapy, as well as something called, and this is for the SLPs, visualizing and verbalizing, because this really helps work on that right-left connection with language. I recommend Amelia use captions, read along with audiobooks, turn on those real-time lyrics if she's listening to music. These are all ways to just kind of do some simple auditory training on her own. She's active in music, that's great, keep that up. These are just like really general recommendations for making home and social situations a little bit easier. Hearing protection, and then I don't know if Amelia has a smartphone, but if she does, there are a lot of cool accessibility features on both platforms. So those are just kind of like the general overall ones, and then the academic ones are more in line for school services. I just threw in some suggested goals for working with an SLP would be those that center around auditory discrimination, strategies, and self-advocacy. General support, and I know she has some of these already, so these are just provided as like a complement to everything that's in place. Frequent check-ins, use of repetition, and then rephrasing if the repetition isn't getting through. Visual aids, note-taking assistance, access to written materials, and then extended test time. I know we're short on time, so I just want to really highlight this one. I think she'd do really well with an FM system. If she is going to, this will kind of depend on if she gets hearing aids or not, but there are ways to route a signal to her, either through hearing aids or without hearing aids. But I think an FM system would be really important for her. Even though she did fairly well, she just had mild weaknesses on the speech and noise tests with her hearing loss, coupled with those auditory processing weaknesses. Again, I think she's working really hard to hear what the teacher is saying when it's a classroom that might have a lot of stuff going on in it. preferential seating. I think she already has that one. Having access to a quiet workspace. Being able to wear something like some noise isolating, like open earplugs if she's needing to focus. And then, you know how mom did listening inventories? Amelia and the teachers can do some too that are specific to the classroom. These are just general remote instruction. Excuse me. Being allowed to use certain technologies if any of those are available to her. And then exemption from foreign language requirement if needed. Sometimes it's not. Or allowing her to focus on a visual language. And I'm putting some of these in here for the future too. And then lastly, you know, I just would love for her to be evaluated by a school district educational audiologist or DHH specialist for DHH eligibility, given this like long-standing conjunctive hearing loss. The end.
Thank you. Very comprehensive.
Can I ask a clarifying question? When you say FM system,
Yeah.
was that individualized for the student and teacher, or could a red cat where it's broadcasted to the whole class, is that appropriate, or it would need to be more
Red Cat
individualized?
can go to.
I mean,
Just one
does she have Red Cat already?
Oh, each classroom has a red cat.
Yeah, each classroom has that.
But is it be
Can it
used?
be just for?
Is it used all the
Amelia?
time?
I use my red cat. When I taught summer school, I had a student and it connected the red cat, the mic I
Yes.
wore connected to his hearing aids.
Yeah,
Oh.
that's
Like
if she has
directly
hearing aids.
Right.
Yeah.
That's if she has hearing aids.
Oh,
She
yeah.
doesn't have hearing aids
Right.
right now, so it would be a different
The red cat's like
system.
a speaker for the whole class.
Yeah,
Is that okay, or
I
you
saw it
want
in
more
action
individualized?
earlier.
Dr. Veer, a more individualized or for the whole class?
I think it's fine as long as there's somebody that can go out and make sure it's working correctly.
Okay. Yeah,
Um,
all of our classrooms use
I'm
it.
sorry, I know you have your hand up. Could you say something real quick? I'm just gonna mute myself.
Yes, thank you. Hi, I appreciate that. So, this is Ajaria Manchego, the deaf hard hearing specialist. And thank you so, I don't know who asked the question, but thank you so much for asking that. So Pleasanton Unified School District did purchase district-wide RedCast systems, and they're in place for all students. And it does amplify the teacher's voice, and it is monitored, or we could have it monitored by the school site technician. And then I do have a couple of questions that are very important as far as I know that at this time, Amelia is not utilizing the hearing aid. What is the actual classification? I know she has the conductive hearing loss, but you said it was mild. What was again the hearing loss?
Yeah, it is. It's a
Moderate, right? The moderate.
It's moderate in the left ear. I like to use minimal too, like one
Okay.
level ahead of mild. So
So
yeah,
you use like rising, so I could say like moderate, rising to mild, and then sloping down again to, okay,
Yeah,
beautiful.
in the right
Okay,
ear.
I just wanted to make sure that when I type up for my report that I use the correct terminology, so thank you.
Yeah,
Okay.
of course. And I kind of explained to the team also, like,
Mhm.
her speech recognition thresholds have been like 20 and 25 consistently with the old
Mhm.
Kaiser audiograms too. And
Mhm.
how, you know, for adults we're like, oh, that's okay, but for kids it's a huge difference when she's needs 20 dB more than her peers, you know.
Right. Okay, thank you so much for that. And my other question, just because I think it would be very helpful for everyone as well. Is there something at this time that's impeding Amelia from being able to utilize hearing aids? I'm not familiar with the case, and so I'm orienting myself, and I'm sure as the rest of the team as well. Is there a condition that would not allow her to utilize hearing aids at this time?
She has the loss was just found significantly in the last 6 months from her last audiogram, and so it hasn't. This is the first time that we were informed of the severity of the rapid loss, according to Dr. Beer's most recent evaluation. So, as a parent, there would be nothing to impede for that to be of consideration. And Dr. Beer, I think you were going to say something.
Oh yeah, I was just gonna explain, she has these perforations in her eardrums, and there's been one failed attempt at patching. So, I think the family's also trying to figure out like if she's a candidate for another surgery, because if she is, that'd be amazing if that could, get rid of the conductive loss. But if she's not gonna be a candidate for that for a while, and I think the Kaiser audiologists were thinking, oh, this is just a pre-surgical hearing test. We're not going to recommend hearing aids. But since it didn't take, I've made the recommendation that if she's going to be going a lot longer with the loss, that hearing aids are recommended.
So, and just for the record, it's a second failed attempt. She's had 2 surgeries, not just one. One with Kaiser and one with Stanford. It was a patch with Stanford, I think, 2.5 years ago, and then this more invasive procedure was done with Kaiser. We only, and I apologize, I don't recall which ear it was done in. I might have sent that to you, Dr. Beer, you might be able to clarify, but that one failed as
I think it
well.
was the right ear, but I will have to go back and look at all the Kaiser notes.
So, and realistically, will not be able to entertain any potential options for candidacy for surgery until the summer. It won't be able to happen. Just FYI.
Can the Red Cat fully integrate with the patient's hearing aids?
It can if she has them.
Great. Okay.
Which she doesn't.
Right. So I'm like, okay.
Every time I could sit her right
by it.
next to the red cat. So
Yeah.
it's like right in her.
Yes.
Like I said, that and Jara, you weren't here for that. This is pretty. This is new information for the family, so unexpected. We were aware she had a minimal loss, but not a rapid decline in the last 6 months. Was not expected to be on the radar.
Thank you so much. I appreciate the feedback. And then just one quick recommendation, just because, Dr. Beer, please, correct me on this if needed, but I strongly recommend not to place Amelia right next to the Red Cat system, just because there is the reverberation and things like that. So the way how sound is, how to explain this, moves around. So if it's too close to her, it could actually muffle the sound. So having some distance between her and the Red Cat is going to actually be good to allow that sound to expand a little bit more, and then it comes across a little bit clearer. So I found that a lot of my students prefer some distance between them. And I'm more than happy to come in and work with the classroom teacher to provide guidance as far, between now and when we do assessments and things like that. But to say, oh, this is a good distance between Amelia and the Red Cat system. And the other thing is we want Amelia to associate positively with the equipment as well. So we don't want her to feel self-conscious about it. And then the other thing I was thinking about real quick is that some of our students, if it's too close, it can cause headaches and other things. So I just wanted to make sure that I put that out there for the team.
Thank you.
Oh my gosh, that's fantastic. So well said. And that's also kind of what I meant when I said, well, it's appropriate for her, so long as there's somebody that can go out and make sure it's set up for her in the way that it's going to work best for her. And I agree with everything you said.
So a clarifying question though, the FM directly to a student is only if they have hearing aids. Okay.
Yeah.
Otherwise, it amplifies for the whole class. Okay.
Yeah, there are different types of FM systems, but with the Red Cat, they're able to, from my last understanding of it, they can also put in this little thing in the back, and then that will route it directly to the hearing aids.
Yeah.
So I guess my question is if, and the rest of the team hasn't explained this, but if there's not time to get the hearing aids between now and the end of the school, is there another type of FM device that could be provided to Amelia to assist in the lieu of the hearing aids potentially that she may not have? I'm more concerned that we have 8 weeks of school and how to help her in the moment would be my question.
We do have, Ms. Bitcon does have a personal one.
Yeah,
that
'cause
we use in the resource room.
But my question would be, would that be available to Amelia?
This is Jara speaking. So one of my things that I guess I want to put out to the team is so the RedCat system does equivalent a really great job of amplifying the teacher's voice. Having said that, the FM system that the other teacher might have, they still does it have an earpiece? Because it
Yes.
would only work if we had an earpiece
Yes.
for Amelia to wear. So the only way for her to hear something directly would be to have some sort of a device available to her.
It
Now, if you get a generic, if you get a generic device, let's say, it's not going to be mapped to her hearing loss. And
No.
Dr. Beer, please correct me, if I'm that needs correcting, but so my only concern with for providing her with just a general amplification device is that we have no control over the specific type of hearing loss that she had. It will amplify the sound just as a RedCat system would. The RedCat system, you can control the volume settings, so it does give you a little bit more flexibility, but with this other device, and I don't know the one that they currently have in place, but I'm just speaking like in general, if we were to get some other type of equipment, we wouldn't necessarily be able to control how much sound's coming through. So I just wanted to put that out there to the teams.
Okay, it sounds like
Yeah.
the RedCat is more sophisticated
Yeah.
in that sense then.
Yeah, we have the X-Max.
Very
I
generic.
would think that with 8 weeks left, like Kelly, if really, I think the best thing would be for someone to make sure RedCat is at the appropriate distance for her, so she can, because it is a good system. And I agree with the point about these other ones, like there's something called Roger Focus. It would just be a blanket increase in her ears, and I would rather have it go through hearing aids that are fitted for her.
Sorry, and I have to add something else, Ms. to this, and again, and you'll get to know me, I'm very student focused, student centered, and all about what they need, and so, again, it goes back to association. She's never worn hearing aids before, so if we expose her to that other device that doesn't have those settings set for her, it might actually discourage her, from wanting to wear one, because she's like, she may not enjoy the other one as much as versus if we do wait and she does get the hearing aids that are properly fitted for her, she might have a better association with it. So there's something else that I wanted to put out to the team, so thank you.
That's a good point.
Yeah, that's a good point.
Oh, where are we time?
153. So,
153.
Ms. Manchego.
So, okay, so no, I'm just trying to summarize too, because we're 7 minutes. So I'm hearing that Jaira would come and work with Taylor on the proximity and maybe the volume sophistication. Is that what I'm hearing?
That's great.
And then yes, that is
okay.
correct.
Okay, and then I heard you say something. You kind of alluded to the assessment component, and I know that I think I saw something tentatively on the schedule for the end of May for her annual.
Yes.
Is that right?
May 24th
26th.
or something.
Okay. So, Jaira, would that give you enough time to complete the evaluation? Because that's a little less than 60 days.
I will do my very best. Yes.
Okay.
I
don't want to
will
rush
have
you.
collaborate with Taylor, and then schedule. Please know as I'm not able to see the parent, but I just wanted to let you know that there might be possibility for Amelia to miss some class. Usually the tests that we do, and it might be a total maybe possibly 4 hours of testing, and then because we have to take into consideration that there is the hearing loss, there is also central processing, so it might take a little bit longer, but I usually test students maybe 30 to 45 minutes, and I will, once I go in and help Taylor set up the equipment, I'll kind of stick around to kind of observe a little bit to see if I can go the full 30 to 45 minutes or so with her, kind of gauge Amelia's personality and see how much she can do it in one time, but I think I can accomplish it, by the end of May, but just know that I'll have to chunk it basically. So she might miss a lot of,
not, I won't take her like the full day, but she might miss a couple of classes, depending on when I go in, but I will collaborate with Taylor to let her know ahead of time, like when I'm coming in. And if there's something important, of course, a test or anything like that, I won't hold her during that time, but, I think I can do it, yes.
Okay.
So, can we talk about options for support of the, sessions to meet with the SLP?
Shandi? Yeah. So
Or yeah.
go ahead. Did you want to?
Yeah, no, just the two things that I, coming into this meeting, wanted to really advocate for is the auditory processing therapies, or the support to help Amelia with the skills and on that. And then obviously I assume we have to talk about an amendment to her IEP for OHI for the CAPD.
To add it?
Well, because we have to
We have to,
amend the IEP.
no, we don't have to assess it, or we need to ask Tin because she was the psychologist that originally designated the eligibility category.
Okay.
So
Because
we need to bring her in.
Yeah, because we need to.
We can't make the decision is what I'm trying to say.
Okay.
We're missing a game player.
So it is going to be critical for me moving forward, especially into middle school, that eligibility be amended into her IEP.
Yeah, so what I'd like to ask for, because they're not here and part of the team, if we can get a secondary team meeting just specifically around that amendment with all team players who can make decision making. It's very timely and very important that happens sooner than later.
For the eligibility?
Correct, in terms of there's new findings, so having anyone that has the decision and making any amendments to eligibility categories right now.
I agree. I agree with having the school psychologist at the next meeting to review eligibility. I think we need to coincide it with the DHH assessment because there's another eligibility potentially on the table.
It can be twofold because there's two things going on, so it could happen in stages. My concern is time is ticking. We know some support needs that have been recommended specifically around the auditory processing disorder, which has been confirmed. There's a secondary potential under deaf and hard of hearing category, OHI. I think we may need to look at this in stages. And again, as Melissa really nicely put, they kind of coincide with each other, but they also need specific support.
And I do agree with Dr. Holly because, the original intent for this meeting was CAPD, and it kind of diverted into some of the hard and hearing priorities. So, the eligibility and getting the classification for CAPD, I don't want to miss any more time. We have 8 weeks left.
Well, the OHI, just the eligibility itself would not have bearing on any services we offer. The services that were recommended were through the speech and language pathologist. And Ms. Dean, maybe you could speak to what information you would need to be able to consider offering services.
So you're saying you can do the services even though we haven't done the amendment to the IEP?
No. I'm saying OHI eligibility is kind of over here. It has no bearing on whether or not we offer services to support CAPD. The eligibility is the eligibility. OHI wouldn't change whether we offered her services to support CAPD.
Well, okay, I'm not really.
DHH is a category that would need to change to offer services to like Gyra. But OHI, she could keep her same category if we were going to offer services. One doesn't have to happen with the other.
Yeah, I think that the biggest thing is just looking at what services can be offered right now, either with an amendment or under the existing category, kind of catch-all as OHI, with the central auditory processing disorder, so we can get those services and make use of the rest of the year for this transition.
Okay, so
with the SLP recommendation.
In 10 seconds?
Yep, there you go.
So we want to treat the deficits. We want to look at how this was one snapshot in time. I really need to know how Amelia's functioning. When I assessed her last year, there were no red flags. She had excellent language skills. So this is a lot of recommendations, some of which are a little bit less based in full, I guess, evidence-based practice that I would like to recommend going forward.
I'm not following, evidence-based. Dr. Beer gave a very comprehensive report in terms of her central
Right.
auditory processing.
So the computer-based auditory training, there's some studies that say, yeah, this might help, and some that won't. It's pretty time consuming, and I'm very protective of the students' time, particularly given Amelia seems to have a lot going on. I see she also has executive functioning concerns. A lot of that overlaps with that profile for auditory processing. So sussing out what specifically do I need to do to help Amelia achieve the best she can in our educational setting, I would need to look at a little bit more.
Look at what more?
So look at her, when you initially requested the evaluation, the concern was expressive language. So that was what last year's assessment really focused on. So I could look at more comprehensive narrative language assessments to see what is she actually gaining from these narratives. Could do more classroom observations. When I observed her in the classroom, I saw full participation. I saw her reading aloud. I saw her following discussion. I didn't see necessarily.
But Dr. Beer is talking more about, in terms
Right.
of functionality of how she's getting tasks done, which she was identified, with inattention, having to be redirected. So I interpret a lot of the challenges that Amelia's been having in the classroom, slower to get her work done, could be attributed to some of these challenges.
Right, and she has accommodations that get put into place to help her with that, allowing for increased processing time.
So I guess what I'm trying to say is that Dr. Beer has recommended very specific supports for, and this is what my ask is, and not just observing her in the classroom, but this is the specifics in terms of where she's identified that noise discrimination and giving her some of those strategies that Dr. Beer has identified. So that's the kind of support that I'm hoping to look for, and if that is an option.
There's not really a noise, or maybe that's
The specific strategies, Dr. Beer, let's see what page that's on. Dr. Beer, what page is it on in the report where you talk about the SLP, the support strategies that you would envision could help?
Yeah,
It's under the summary and recommendations.
yeah, and this is why I kind of separate out some different recommendations,
We're
because
gonna
I'm
do
not
it
in a
to pause it.
position to be able to
Page
tell
9.
the school SLP what to do, right? But in following ASHA guidelines, sometimes we've had students who will work with the school speech language pathologists on those strategies, more the top-down stuff, and maybe they do auditory training elsewhere, right? I'm not in a position where I can tell a school district to buy a specific auditory training program. That's not what I'm doing. I'm just recommending all the things that could potentially help Amelia based upon guidelines that are written by the American Speech Language Hearing Association.
Guys, I think I have to be the camera right now. Unfortunately, I'm sorry. We have to get a sub to the next spot because we have our next meeting that's out in the lobby. So what do we need to do, Aura, for?
It sounds like we need to continue the conversation.
Okay.
The only thing I heard was that Ms. Dean would like to do some further testing, and Ms. Jaira wants to do the DHH component. So
Yeah, so
Holly can schedule a part 2 so we can continue the conversation, and then perhaps so we don't lose ground, we can at least get the assessment plan out to the families so they can review it.
the assessment plan?
If we take out the
That's what we
assessment
call the
plan for
papers to
conducting hard
consent
of
for
hearing
testing.
assessment that's gonna be conducted, that would be great, and at the same time in tandem, just get a part 2 on the
Right.
books of this meeting, because a lot was not covered that the family needs to address.
Right,
Perfect.
yeah, that's what I'm
Alright.
saying.
And
Thank
sorry,
you.
this is Jara, two things. I did want to share that recently, our district did change the procedure for how we do, the assessments. And so my goal is to be able to send this out to you by next week, and have you have, via DocuSign, sign the document. And then after that, I'll submit this to our district, and then
Thank
we
you.
can continue on. But, you should hopefully hear from me with the assessment report either by Monday or Tuesday, okay? But it would be coming to you through DocuSign. And then my last thing is I do have to go to another meeting and I'm so sorry. May I be excused?
I think we all have to go.
Yeah,
Thank you.
just